Andy, can I come back on continue on another? Is that okay?
Yeah. Yes, please, Steve. Yep.
Just on 1875, where we're talking about the scaling back of delivery, and there's a reference there to there is a risk about the lack of referrals. I'm not sure we pick this up in any of the risks, but around serious incidents, and whether because of our higher entry criteria and in effect the earlier discharges that have been taken under good clinical conditions that have been taking place during COVID-19. I think we need to make sure that we picked up somewhere, and I don't know if it should come under 1875, that that is a risk, that because of that change in clinical judgments in those two critical points, there is a risk of an increase in serious incidents over time.
That is covered, I think, towards the end of the description, Steve. So it's kind of the last sentence in 1875.
Yeah. Do you mean in the description?
Yes. Yeah.
I think we should make a specific reference to SIs. I see what you mean, because there's potential increase. Yeah. Okay. Thank you. That deals with it. Well done.
Okay. On the Steve James, on the 136, please.
Thank you. I suppose it's important that we're clear. The mental health group said that the trust should create a definitive statement about its position in relation to 136 breaches, and that would then be discussed by the board. We haven't, for very understandable reasons, managed to do that. So my understanding of the risk as it is that it stays until that happens. And I also think it's worth considering what we're going to do about 136 breaches, because one of the things we will need to demonstrate is that we have done everything in our power to not have breaches occurring. Is that we currently have we have empty beds, and that when we start to reintroduce those beds back into the system, we need to consider whether or not potential 136 referrals are probably the priority in relation to the use of those beds in the future, because we're in a different position now to the one we were before. The 136 breach thing is very complicated because there isn't a definitive legal position, and anything we do will be challengeable. So that's why the statement is so important. So I would encourage, when we have the time, the executive, really as a matter of priority, to deliver that so that we can discuss it at the board. But at the moment, I think the risk stays where it is.
Iffy?
I'm content with that. I think just to help the board understand what we've been doing about the 136, you will know that we currently are rebuilding the 136 on the Oxleas House site, and in a month or 6 weeks at the outside, we'll have 2 suites on that site, and then we'll shut the Green Parks House site. What I would recommend is that we bring to various groups and committees, and hopefully up to the board, what the new arrangements will be on the Oxleas House site. What I'm anticipating is that the responsibility will sit clearly with the Greenwich Directorate, who will make sure that they monitor any breaches. And we've been also very clear about the process to date. And you will recall that the auditors have been through this. At a patient level, we expect, if any detentions were to be, if anyone is to be held beyond the 24 hours that the law allows us to hold people, that there's a risk assessment that clearly says why that's happening. We expect the patient to be informed, and we expect that to be documented in the clinical notes. And we then expect the directorate to go over that incident and to report to the exec. I think it will be really good that at a weekly meeting with Andy, where we look at risk issues, that we bring that up to that meeting. So on a weekly basis, we would know what's going on, quite apart from it coming to the exec meetings and then the mental health log, PQAC, and then up to the board. So I, in principle, agree with you, Steve, that we leave things as they are. We get a paper through the respective groups that are applying some of the things I've said in readiness, or at the same time as we open up the two suites when they're ready at Oxleas House.
Steve?
Yeah, thanks. I think that covers it. We'll wait for the statement and leave the risk where it is for the moment.
Andy, can I just come in there?
Yeah.
And so just to be very clear, so what we're saying is at present, we're not yet tolerating this risk. We're not taking it off the BAF, and we're not looking to reduce the risk rating. Is that correct?
Yes.
That's correct, yes.
Okay, thanks for the confirmation.
Steve Dilworth, you're happy with that?
Yeah, I mean, I'm not sure the risk rating was actually affected in that sense. The point of if it was done on a toleration basis, it was just to say there's nothing more we can add. You know, there's no point in leaving it on the BAF if, in fact, it's just going to remain much the same. But you know, if very happy if there's further work that needs to be done on it, and it's on that basis. But it's certainly no one was thinking in any proposal that this diminishes the importance, just so long as everyone understands that. You know, there was no thought in any quarter that this matter goes away or is less important.
May I just come in? I completely agree with that. I don't think that this was about reducing the risk. This was more about, my sense is that when it's on the BAF, the board is reassured that they are cited on it. And then when not on the BAF, the board wants the assurance that there are good enough systems that continuously review this and that we're on top of it. And that's what I'm suggesting that we'll bring through the respective groups to the board at a later date to give that assurance so that we can then have this discussion about tolerating the risk and getting it off the BAF.
Okay, I think my point was based on narrative in the papers that talks about this issue going back to PQAC and for PQAC to then look to reduce the risk rating. That's more where I was coming from.
Yeah, there's that piece under 1776, the second paragraph. I don't think we can agree with that at the moment because it's asking support staff if a decision is made to detain a patient. And it just sits there almost asking the board to do something. And then, as you say, the MSC, it talks about PQAC reducing the risk. If I can just summarise them for a moment. The Greenwich Directorate will be responsible, will they not, for oversight of this on a daily basis. The exec will be responsible for dealing with any breaches of the legislation on that and taking any appropriate action they should on that. On the Tuesday morning meetings, that it will be an item that comes up, and that the mental health group and PQAC will be receiving reports in slower time. The statement from the exec, I take it, will go through PQAC ultimately and through to the board, and then we can make a decision to reduce it or take it off the BAF. Is that okay, Iffy?
That's correct. That's okay.
Okay, thanks ever so much. Anything else on that at all before we move on? If not, sorry.
Andy, it's just a point of clarification. So because of a slowdown in the progress of the works at Oxleas House, our latest understanding is that we will have one of the two suites up and ready at the beginning of June, but not both. So there will be a period of time where we will have a suite on two sites. And obviously I'll update the board as that situation changes.
Thanks, Ian. So as in the interim, we're saying then the Bromley Directorate and the Greenwich Directorate are responsible for oversight of what's happening on those suites. Is that correct? Yeah.
That's
fine. Okay, thanks very much. We're going to move on to item 5, and that's you, Iffy, I think.
Muted, Iffy.
the paper which discusses the new governance arrangements that we put in place on account of COVID-19. In making the changes, we have sought to ensure that we satisfy external regulations and also bring some degree of focus to the pandemic. We've certainly managed to keep NETs informed through the weekly briefings. So you'll find in the paper the new structure and the number of enclosures that really describes the arrangements we've put in place for incident management, arrangements for executive team meetings, financial governance, as well as arrangements that we have for meeting with the CCG, CQC monitoring, etc. So the board is essentially asked to note these changes and consider whether this provides sufficient assurance to the board.
Firstly, if I can say, a big thanks from all of us for everything you and the exec team have been doing in managing this, and it's a very helpful paper outlining the arrangements you have in place. I'll now invite colleagues for any observations they may have.
Andy, could I just ask about the ethics group?
Yes, please.
Yeah. First of all, just to say what you said, I think this is a very comprehensive governance arrangement, and certainly from discussions with other organisations, other NHS organisations, I've mentioned this to you before about what other chairs are saying. I actually think we're ahead of the curve on this. We're better placed with NED oversight and involvement than a lot of other trusts and organisations are around the country. I just wanted to ask about the ethics group, which I think basically works very successfully. And I don't think to date there have been any really major and significant decisions. And I don't want to, in saying that, I don't want to underplay what the decisions they have made. I'm just thinking that presumably there could be some very significant decisions being put before that group. And in those circumstances, what would be the process for speedily involving the NEDs in that discussion and or what decision has been made?
Let me take that. So the ethics group does include a couple of NEDs. Both Suzanne and Steve James are members. And we've pretty much tried to convene on an ad hoc basis, bearing in mind people's availability. And so once any decision is made, that goes through the usual routes, and it will certainly be discussed at the exec meeting on Tuesday, and then the NEDs will be informed in our usual briefing on the same day. And that's the current arrangement.
Yeah, I was appreciative of the NEDs already being on the group. I just wonder if there's, so it was for the other NEDs, and I just wonder, could you envisage a circumstance where the decision you made is of such magnitude that in fact you couldn't wait to the following gathering of NEDs on the Tuesday, and what you would do in that sort of circumstance?
Well, I can't think of any, but certainly if that were to arise, I can make sure that that's one of the things that the ethics group will consider. The decision that has been made about particular issues requires much quicker cascade to board members. We can certainly have that as one of the criteria to look at.
Thanks, Sophie.
Yeah, Joe, did you want to come in? Sorry.
Oh, sorry, Andy, because I'm on the phone, so I can't tell who's asking questions. Apologies.
No, you go ahead, Yemisi, go ahead.
Thanks. It's just a quick one from me. Is there a proposed timeline as to when you want to continue using the COVID governance arrangements, And has there been any thought of when you wanted to step down to maybe go back to original arrangements, or were you looking to incorporate this into arrangements going forward?
We want to continue this. In the first instance, we're thinking about 3 months, and then we'll review thereafter.
Okay. Thanks.
Okay, Joe, on terms of reference.
Yeah, just going back to the ethics group. So I've just had a sort of a chat response from Suzanne that the terms of reference of the ethics group has been approved at PQAC, which is great. I think it would be quite useful for the rest of the board to see them, and apologies if I've missed them. So I think that would be helpful.
Circulate to the rest of the board, definitely.
Could I make a comment about the ethics group as well? I don't actually agree with you, Steve, that it hasn't been making decisions which have some quite serious consequences. And I think the decisions which the ethics group has made about whether we should follow the Resus Council guidance on whether or not chest compressions constitute an aerosol generating procedure, which the Resus Council says they do, and therefore require full PPE, as opposed to the Public Health England guidance, which said that they were not. We decided as an ethics group that particularly in relation to a query that was raised by community staff, that we should resolve that difference by adopting a prudential approach and providing our staff with fit masks, full FFP3 masks for the occasions when they might need to be doing chest compressions. I think it's a serious decision because it requires you to establish a priority around the extent of our duty of care to staff, the nature of our duty of care to patients, and whether or not we're going to deviate from guidance coming from Public Health England in favour of professional group guidance. Now, I would see that as quite a serious decision with quite serious ramifications.
Okay, thanks very much. Rachel C., did you want to come in on a comment?
Yeah, just briefly. So the second paragraph of the Oxley Executive Meeting Arrangements talks about the primary focus of meetings being on the organisational response to COVID-19. And I think that's absolutely right at the time that this was drafted. But as this pandemic continues into a kind of longer new normal, as it's called, I think it is going to be important that we also start where we can and where we have capacity to reintroduce some of the elements that we need in order to make the organisation run effectively. So I would see that over time, as we already have been, that we would be keeping these arrangements under review, and that perhaps over time the balance of the agenda items and the contents of those meetings might continue to focus on COVID, but bring other things into. Otherwise, I think we can't continue for 6 to 9 months without dealing with some of the more regular business that we need to deal with in order to keep the organisation running effectively.
Yeah, thank you, Rachel.
And it might just come back on the ethics, because if colleagues look on the slide on page 28, it's very clear that the ethics group makes recommendations to the task force meeting, the COVID-19 task force meeting. And certainly that's all they can do. So the GOLD meeting will decide whether to accept the recommendation, and then the exec group will also be involved in that discussion. Thank you.
Thanks, Iffy. You're asking for approval for this, is that correct?
Yeah, that's correct.
Colleagues, do we approve? I'll take that as an approval. Right, thanks very much indeed. If we can go through to item 6, Ian, please.
Thanks very much, Andy. So what colleagues have in front of them is a slightly different paper around service delivery for this board. And it comes in 2 parts. There's an operational update, which really tries to set out broadly some of the changes we've made to our operating model during the pandemic. And I'll talk a bit more about that in a moment. And then the second item behind that is a revised dashboard, which, given the changes in service delivery, the executive were keen to have a suite of indicators which enable them to see how things were going during this quite difficult time. So in terms of the approach that we've taken, I think colleagues are aware that at the beginning of the pandemic, we implemented our business continuity plans, and that has seen a degree of prioritisation take place. Priority has been given to maintaining inpatient services and ensuring continuity of service for those in most need within the community across all our care groups. It goes on to, the paper goes on to list a number of service changes that have taken place during the course of the pandemic, and these are to respond to changes in demand both internally but also within the wider system. And as part of our recovery planning, we will of course be reviewing these service developments to see whether they have long-term benefits. Just on, I won't go through all of those, but just to give you one update, in terms of our work with Demelza Hospice, I can now confirm that that went live as of yesterday. The paper also highlights the fact that there's a lot of work going on as a system, both at a local level within the 3 boroughs that we operate, but also in the wider ICS. And particularly, I would say, around community health, and this is mainly because of, understandably, because of changes in demand in our acute, with our acute partners. It's really important that the rest of the system works with them to ensure that there is a kind of a proper wraparound. And a lot of that work was something that was already underway, but the situation that we find ourselves in has speeded up some of that thinking. And again, I'm happy to take any questions around that. And then finally, on this first bit of the paper, it just talks in a bit of detail about the incident control centre that we've established at Pinewood House, which is the mechanism for keeping tabs on how we're doing day to day. And there are a number of important key functions that it delivers. One is the number of situation reports that we have to produce for the wider system. Secondly, around the kind of access and distribution of PPE throughout the organisation, communications, and then oversight of staff swabbing. And obviously, one of the things that we will be thinking about is the need for that to continue and how long those arrangements might continue. For now, we are very much seeing that the ICC will continue for the time being. We are already scaling back on the number of daily phone calls. So colleagues will be aware that every day I chair a call with kind of the directorates and a number of other corporate colleagues, which is a daily call just to understand how we're doing. We've made the decision to scale that back down from 5 times a week to 3 times a week from next week. So I'll pause there, take any questions, and then I'm happy. Then I'll go through the dashboard if that's okay.
Any questions from colleagues?
Ian, just one from me. Just really pleased to hear you say that some of the decisions in relation to ward closures and other service changes will be reviewed actually to see if they have any longer term benefit even after the immediate kind of concerns kind of move into phase 2. Just conscious that Alison and I had a conversation with Lorraine in the Adult Learning Disability Service, and the closure of Norman Ward is one of those closures that we might want to be part of that review process, which I'm sure it would have been anyway. Needless to say that there's a huge school of thought that considers that, you know, obviously for that particular patient group, being able to support them more in the community is absolutely the right thing to do. So just to say, pleased to hear you say that, and hope that Norman Ward will be part of that review process.
Yes, thank you, Amlan. Absolutely. I mean, as the dashboard describes, we have temporarily closed 3 of our adult acute wards, and that is in response to a reduction in demand, and also it enabled us in the early days of the pandemic to manage any particular surges in staff absence. But demand for patient beds is something that we are monitoring on a daily basis. And what I would say is that we are starting to see a slight increase in that demand. If you look on the dashboard, the numbers of people who are in our beds, there is a slightly higher proportion than normal of detained patients. So we are, I'm reassured we are treating the people who most need our services. But absolutely, that is something that we are starting to consider about, where do we want to get to, and where do we need to get to in terms of how many beds we have in the system.
Thanks. Nina, did you have a question? You're still muted, Nina.
I just wanted to direct the question that Christine had asked us earlier from a staff governor perspective, if I may, to Alison. And the question was around how we are ensuring that temporary staff are gaining access to IT and things like being able to access patient records.
Yeah, hi Nina. The process that we have in place for temporary staff is exactly the same as we have for permanent staff. So we have to follow the same processes, the same registration authority processes for staff to get access to patient systems, etc. So there's no change.
Thanks, Alison. Christine, does that answer your question?
Hello.
Hi.
All right. Okay. Not quite, because we have a lot of temporary staff on the wards that can gain access to equipment or RIO, mainly because they do occasional shifts rather than being part of the trust. So it doesn't really answer my questions, because we do work with colleagues who can access our systems on the wards.
So, Christine, I mean, I'm happy to have a conversation with you after, but broadly, in terms of new staff coming into the trust now, they can do RIO training online, so that shouldn't prevent them having access to the system. And in terms of access to equipment, that will be down to a local organisation, part of the organisation, to arrange. Now, at the moment, there is obviously some delays in getting new equipment in, and we are trying to get more laptops, and we have a whole heap of laptops ready to be given out to staff that have come in from the STP. So there may be some issues in terms of actually getting equipment out to staff, but the processes should be the same as normal.
Okay, thank you.
Joe, you want to talk about ask about UEAs?
Yeah, I was just saying, I mean, as Ian pops through the dashboard, I'd be interested to know where we are, the number of UEAs we have at the moment. We had reported at business committee that there'd been quite a surge in March, and I think when we met at business, I think we were down to just 2 or 3. But it'd be interesting certainly if we're seeing demand coming up and we've got some wards closed, where we are on that. Thank you.
Sure. So Andy, shall I just take colleagues through the dashboard, and I'll highlight some particular areas, and obviously then I'll happy to take questions beyond that. So the dashboard, this format of the dashboard is something that the executive is looking at on a weekly basis in our Tuesday meetings. The information that you have contained in the board papers is data up until the end of last week. So just to kind of highlight a few of the slides. On slide 2, you can see that the number of staff absences has been on the decline since the beginning of April. And on on the second of those slides, it shows the number of absences which are related to COVID-19 as a proportion of the overall absences. On slide 3, it takes you through the numbers in terms of confirmed inpatients and the fact that that has reduced. And there has been a slight increase in the number of confirmed prisoners, and these have mainly been in the Greenwich cluster. But overall, within the prison population, there has been a decrease in symptomatic cases. And that increase in the numbers is, I think, down to the fact that there's been more extensive testing happening. In terms of our latest inpatient figures, as of yesterday, we had 7 inpatients who were confirmed as having COVID-19, and all of these were within our intermediate care beds, and we have a further 16 waiting for results. And as of yesterday, we had a total of 44 people in prisons. In terms of PPE, obviously this came up earlier, but on slide 4, in terms of our RAG status, we're currently at green. There was a slight concern at the beginning of the week about access to gowns. However, that has now been addressed, and we have now got the supply of gowns that we need. And I'm assured that we're okay in terms of our supply for at least a week, which in kind of terms of how we're managing the situation, that's reassuring for me. There's a question before from Joe around mental health bed availability. So slides 5 and 6 give you a picture as of last week, and just to reiterate, we have currently got 3 of our acute wards closed. As of yesterday, going into yesterday evening, we had 4 people in the private sector, with a further 2 expected to be referred into the private sector overnight. I've started the conversation with service directors about the possibility of opening up one of the closed wards next week, and I will have a meeting with them on Monday to progress this. I think if we are going to open up one of the wards, it would make sense to me that it would be one that is mixed sex, because it's very difficult to predict who needs to be admitted at any given time, so it gives us a little bit more flexibility. In terms of what you haven't got there is data around our intermediate care capacity. I mean, I think I've highlighted in previous NED briefings that we have slightly changed our operating model around our intermediate care beds. So at Meadowview, we are operating intermediate care for Greenwich and Bexley. And at Eltham, we have started accepting neuro rehab patients as well. What I would say is that the number of referrals has reduced to both services. So as of last night, we actually had 10 vacancies within Meadowview and 11 in Eltham, and that's within the 30 beds that we operate at each site currently. I think colleagues are aware that we have got capacity to go up to 40 beds if necessary on both sites. On slide 9, there's some detail around our referral to first appointment, and there has been some drop-off in that. Again, I think that is in the context of prioritisation of services. But I thought on on slide 13, you get a sense of how we are conducting our business, and you will see that there has been overall in both our mental health and our physical health services a decrease in our face-to-face contacts, but there has been at the same time a huge increase in the number of virtual contacts. And you have got detail on one of the slides about a breakdown of how those contacts are being conducted. The other thing I just wanted to highlight on one of the slides was that you will see that there has been an increase in our community health services around provider cancellations. And I just wanted to clarify that a number of services have been put on hold as part of our mobilisation of our business continuity plans, which has been further reinforced by national guidance around community health services. And one of the services that has been temporarily suspended is our Bexley MSK service, and so that accounts for a number of those cancellations. So that's what I drew out as kind of highlights, but obviously happy to take any questions from colleagues.
Suzanne, you had a question.
Well, the question about community cancellations has actually been answered. Thank you very much, Ian. I found the dashboard really useful, actually, and very helpful to give us a sort of capture where we're at. My only other question actually was about inpatient testing. And I was wondering what the turnaround is on the inpatient testing, because this is, or the testing in general, in that that's going to have a major impact on our ability to start to bring services back on stream. And just to be clear about why I'm asking the question, when I spoke to one of our prison service directors, they referred to being provided with kit which allowed them to test and have a result within 90 minutes. And I'm wondering if that was a fantasy, a misunderstanding, or something that's going to be rolled out a bit more widely.
Thanks very much, Suzanne. I mean, in terms of our inpatient testing, as I think colleagues are aware, we now test everybody as part of the admission process. But in terms of getting results back, it is taking a couple of days. Certainly not 90 minutes. I'm very happy to look into that, because if it was 90 minutes, I would definitely want that rolled out across the organisation. And it does, so the fact that there is a bit of a turnaround time does present challenges, particularly in wards where people aren't in side rooms, or there aren't ensuite facilities. So we are managing that at the moment. But I know, for instance, at Meadowview, new admissions are going into side rooms. And we're okay at the moment because of the relatively low level of referrals. But that's something that we're going to have to think about quite closely. I just wanted to make a comment about the dashboards in general, because I can see there's some comments on how it's made up. I mean, this is very much a work in progress from my point of view. I think for Iffy and myself and other exec colleagues, it was trying to have something which highlighted some of the more important indicators while we're in this slightly strange time. I think one of the things we want to think about is whether there's merit in developing it further, or obviously adding in further indicators as we go along. When we first started it, it was very much weighted towards our mental health services. So we kind of make sure that it covers, the sheer variety of services that we operate. But it would be helpful to have comments from colleagues outside of the board.
Yeah, thanks very much, Ian. Alison, I think you had a comment to make.
Yes, thanks, Andy. Yes, I just wanted to make a comment about IAP services. We don't have that data in there, and I think it'd be useful to have it in future iterations. But I received some data last night from the IAP service, which shows just an amazing shift change in terms of the way that they're delivering services. So they haven't really seen a huge impact in terms of the number of appointments that they are delivering, but they're all virtual now. And just to give some context, in February they provided 50 appointments via video, and in April they did almost 850 appointments via video conference, with the vast majority of the rest being done by telephone. So we've seen a complete shift in that service in terms of delivery of care in a very short space of time.
That's really impressive. Anyway, thanks very much. Right, can we move on, please? Item 7, Iffy.
I hope that colleagues have received the additional paper which was sent outside of the pack. So just in summary, all we've tried to do in Oxleas is to respond to the second letter from both Simon Stevens and Amanda Pritchard, asking us to begin preparations for business as usual. So in that letter, in the annex, there was a section that talked about the expectations of different organizations, including primary care. And so we've decided to do a quick analysis of where we are in terms of what we're already doing, what we need to step up, and what we plan to implement. And so that's the paper before you. I think for me, there were just a few things that I want to say about that work. Community health services, as Ian just said, MSK, for example, is one that we need to phase in as a routine service going forward. End of life, there's some work we're doing there, which is a multi-agency piece of work, particularly looking at how we can provide psychological support, and that's really quite interesting. I don't think it will surprise anyone to hear me say that we need to keep a very close eye on demand and capacity. And I think that perhaps in future board meetings, that's going to be where we're going to focus, particularly for our district nurses and some of our specialist community teams on the back of COVID-19. There's a particular comment in there about trusts really looking at inequity of access. So we need to keep a close eye on that, and we'll be having conversations about how we draw out any data that might help us to do so objectively. And then finally, there's been a lot of conversation about how we might manage new patients coming in who may or may not have COVID, and also manage patients who already have COVID. There's a lot of that discussion in the acute trust, but in our trust for now, we've taken the view that we will use our side rooms, we will use the single rooms that we have and the en-suites for all new admissions until the test results, as you heard Ian say, every new patient who comes into hospital will have a test until the test result proves whether the patient is positive or negative, and then we'll take it from there. And that's all I wanted to say.
Thanks very much, Iffy. Any questions for Iffy? If not, thanks very much. Rachel, please, item 8.
Thanks, Andy. So this was the board meeting where I had hoped to be revealing a beautiful strategy with an aligned action plan behind it. And very sadly, that was put paid to by COVID for 2 reasons. So we had an intense engagement activity planned for March and April, but that wasn't practical from a social distancing perspective, but also in terms of the kind of the bandwidth of our staff, who are very much, as you might expect, focused on the here and now of getting through COVID rather than looking slightly into the longer term for the next few years. So we put it on hold, and I had a momentary pang of intense disappointment not to be able to wrap up all of the fantastic feedback that we had from thousands of members of staff, hundreds of service users, and put it together into a nice package that we could all agree and that could help guide us going forward. But I quickly thought about the fact that if there was ever a time for us to show our true colours as a trust about what really matters to us, what our priorities are, this is it. No point planning for 5 years hence, because people will be looking at what we do right here, right now for our staff and for our service users. So the approach that I and others have taken is to try and really extract the benefit of those main themes that were emerging from Our Next Step work as we put it on pause to help inform what we were doing. So what was coming through loud and clear from staff, from service users and from people in our local communities was that they really wanted us to focus on staff wellbeing. Now, health and well-being in the middle of this crisis is going to be a priority for any trust, but what we've tried to do is to make sure that that is absolutely relentless in terms of how we communicate our commitment to being clear, our commitment to turning the guidance around really quickly, to having lots of fora where people can ask the difficult questions and get really quick answers. So we've really tried to keep that focus on well-being, and you'll have seen from the How Are You survey that the feedback has been quite heartening. Now, you know, no complacency, there is more that we are going to do, but the feedback about that, particularly that focus on communications, has been well received. We've also tried to make sure that we've been as visible in our leadership as is humanly possible, consistent with being safe and managing the risks around COVID. And we've also realised, as Alison was just referring, and Ian, to the fact that this has actually provided a setting in which we've been able to do some of the much more innovative service delivery at a much quicker pace than we might otherwise have been able to do. So what we want to do is to make sure that all of that thinking around digital and innovation is something that we keep track of, we understand the impacts of it, so that we can work out what we want to deploy when we get out the other end of this. But the other thing I reflected on was that any beautiful strategy that we had designed at the end of that process in March or April would have probably needed quite an overhaul by the time we got to the end of this process. So in many ways, now is actually the right time, I think, for us to pull together the themes that have come out of the Our Next Step survey, to align that with the thinking that Azra and people in her team have been doing about how we might transform the organisation to put ourselves on a sustainable footing, but also to take account of the big system-wide changes that are going on at the moment and the opportunities that there are actually for us to deliver and design our services in a way that we're really proud of, where we really think about the nature of our services, the therapeutic value of our services, and really drive a clinical strategy. So my hope is that actually this time will enable us to pull a few other themes together into an overarching strategy that helps us to be really quite ambitious in terms of the service delivery that we provide. And the plan is consistent with being able to do things remotely, to try and progress that thinking, pull it together over the next couple of months to give the headlines to the board in July, but with a view to there being a more detailed plan in place for September. That's all I was going to say, but I would welcome comments.
Thanks very much, Rachel. Steve James.
Thank you. I mean, I completely agree. This is really helpful. I completely agree with the things that are in the item. I suppose my only comment is about emphasis. I would be surprised if service users, patients and families didn't want to be involved more in the design and delivery of the services they received. And it seems to me that, of course, I agree that staff wellbeing and communication is really important to a healthy and growing organisation and one that delivers good services. But also absolutely key is the buy-in of patients and their families and people that are close to them. And I guess, I mean, this isn't a finished document, so I wouldn't criticise it for that, but there really needs to be an emphasis as well as on staff wellbeing about user involvement, because one of the key bits to improving outcomes for people is a real involvement both in the strategic planning of the staff, but also their individual plans. And it is something that the Trust does get criticised about. So I think it's a thing about emphasis. It's not to say these things that are in here aren't important, but it reads a little bit like a staff thing, not an organisational thing.
Rachel or Effie?
I wanted to comment. I'm sure Rachel will give a more comprehensive response. But if you look at number 5, it does make it clear, you know. And I think that that we want to work in partnership with service users to make sure that it's the right services that we're providing for them the way they want it, and that we're going to rely on their feedback to continuously improve our service. To my mind, we cannot run a good organization without that being at the heart of what we do. But Rachel, I'm sure you may want to say a bit more.
Yeah, and we've discussed this, I think, a few times, haven't we? So it was set up to have a central focus on staff experience, and so given the way that it was set up, I think, and the reason for it being set up in that way, as we've discussed previously, is because of all the evidence that suggests that the better the staff experience, the better the quality of care that we provide. That said, we had some fantastic feedback through from service users and communities, and there was a lot in there. To be honest, the richness of that hasn't yet been fully been able to be delved into, partially because of Kaleidoscope's impact of COVID on Kaleidoscope as a team. So there is further richness from the service user discussions, but I can highlight some of the things that came through there. Long waiting times was one of the big issues that came through. Following up on with service users after discharge, that was a really big issue. And it's really important that all of these things feed into that service delivery as we go forward. But I think the point that you make, Steve, is a more general one about how well we do service user involvement across the trust. And I think we would all agree that that's something that we want to focus on improving going forwards. We would started to develop a new strategy in February, March, but that's been slightly overtaken, obviously. But I think that will need to be a key element, agreeing how and when we engage service users, both in their own care, but also in the development and design of our services, I think will need to be a key priority going forward.
Yeah, Steve Dilworth.
Yeah, just building on the answers from Rachel and Effie, but also on Steve's original point. I think we would all get the piece about well-skilled, motivated, passionate staff eventually or immediately is going to lead to better treatment for our service users. But in terms of, I think there's two things. First of all, in terms of the communication as it stands at the moment, and there's a lot of really good stuff in there that you put in there, Rachel. It does seem a little bit weighted towards staff rather than patients and service users. So I think and I do, as if he's pointed out, I do see in item 5 what's said there about measuring the impact. But I think that just needs redressing a little bit so that balance is brought back a little bit to where I'm sure you'd want it to be. The second thing, and I know we've mentioned this for over 4 or 5 years, is about providing our value. How does anyone know that what we're doing really works, and how do we show that in fact the community is better off because Oxleas exists? And I think there's a piece in the strategy on that, because that's such an important element. Because at the end of the day, if we're not 100% sure that what we're doing actually is beneficial, we might as well just shut up the shop. So I think there is a key point there. It's not just an objective or something about key performance indicators, but it is something about our overall strategy. Part of that is proving that what we do has beneficial outcomes. And that's all about analysis and evidence. So if you can weave that in, I'd be very appreciative. That's it.
Thank you very much, Stephen. Suzanne, could you come in, please?
Thank you, Andy. I'm slightly worried that I'm beginning to sound a bit like a broken record on this issue of our relationship with the broader ICS or South London Partnership. I do feel that things have shifted quite considerably from when we started our new strategy development, in that I think our assumption at the time was that Oxleas was the starting point and we needed to relate to the wider system. I think that one of the things that has happened with COVID is that certainly those in the wider system are beginning to view the wider system as the starting point and the individual organisations as being bits of the jigsaw pieces, that they may want to move around. I think what I would really like to see as we develop the strategy going forward is a real recognition of the impact of partnership working and how we're going to navigate our way through some of the challenges of that, because I think there are going to be some very significant governance challenges, and I also think that we're going to be playing catch up slightly from decisions which get made during this current period. And I'm thinking particularly about the way in which the capital programme decisions now seem to be being made suddenly with relatively little input from us, despite, you know, apart from us, we're fighting our corner with the other directors of finance. And you know, I think that we're going to have to really understand how these new arrangements are going to work going forward, and how we maintain what's important about the way in which Oxleas wants to provide for patients and staff, alongside our commitments to the wider system.
Rachel, are you able to come back at all?
It's very well made, and I agree.
Could I just add one little point into that, Andy?
Yeah, go ahead, please, Ezra.
Okay, so I think there is something that links this very much to the paper before in regards to how exactly we're going to plan through the next 18 months. And we're still obviously in a process of engaging with our system and our partners in regards to how we are going to formulate the ICS strategy for that 18-month period. That will obviously influence quite strongly our overall strategy for the trust. And I think there is a little bit of the fact that we're still in a period of flux where we're trying to plan some of that over the course of the next month or two. And then I think we would be in a much better position to be able to say that's the springboard for the overarching 5-year strategy. And that will then, I think, take into account both some of the comments that we've had around partnership working, but also some of the issues around how we broaden it out into patient experience. Because one of the issues that we've had in this period of COVID-19 is things like the feedback from patients. Some of those processes have been suspended for the last couple of months, and we just need to reinstitute some of those, and that will help bring a whole range of those type of topics back into that overarching strategy.
I think it's a really good point, Ezra. I think there's some good observations there, and there's some great work done so far, but I do endorse some of those comments about the patient viewpoint. And picking up on Suzanne's comments, that we are in a position now of rather more centralized drive for change. And some of the times I hear fellow chairs arguing that who's representing the patient, almost as if we, the trusts, understand the patients and those at the centre don't. I'm not entirely sure that is true. And if it is true, we need to provide the evidence that we are listening to patients and responding to their concerns. And I think I'd struggle, if I'm honest, to count the number of things that we've changed because of patient view. So I think it's a really interesting one. I totally get it around this. We can't do anything without our staff. Of course we can't. And we're doing outstandingly well at the moment. But nevertheless, I think it's worth very much listening to the comments of colleagues about what they say on that. I'll draw this one to a close, if I may. We'll move on to item 9. And Sally, please.
Thank you, Andy. This paper is to update the board on the revised annual report and accounts timetable. So this year, because of COVID-19, the timetable has been shifted. The key submission date is the 25th of June, and then this will be followed by the report being presented to Parliament. But this is likely not to happen until Parliament resits in the autumn, which would then have a knock-on effect on our annual members' meeting. So potentially our annual members' meeting may not now take place until November. The annual report and the accounts are being drafted currently and will be reviewed by the external auditors. And I will share drafts with the board members informally so that we can have comments. But I did also want to make sure that members are aware of that the personal data will be included in the annual report as normal under the remuneration area particularly. There are possibilities to raise objections to that under GDPR, but I just really wanted to make everyone aware that we will be following that as normal to give the transparency to the public as well. And what we're asking in this paper is that the board delegates responsibility to the Audit and Risk Assurance Committee for the final sign-off of the annual report and accounts to be then submitted to NHS England and NHSI. Our other aspect in the paper is the provider license certification, which board members will remember normally comes to the board and Audit and Risk Assurance Committee at this time of year. This is one of the items that has been highlighted for potential streamlining centrally, but we're still waiting for updates on exactly what is required. So really wanted to flag it up with the board. I mean, it's likely to follow a similar format to last year, and we can take that forward anyway. But again, wanted to delegate final sign-off to the Audit and Risk Assurance Committee. And then I think Azra would like to come in just give an update on the account side of the paper.
Thank you very much, Sally. So just then to confirm on the annual accounts, there were 3 options in terms of submission deadlines for the annual accounts. We went with option 1B, which was the 1st of May. Those annual accounts went in, so they went both to the external auditors on that day and also up to NHSI and E. We also completed the remuneration report that Sally was referring to, which would incorporate part and parcel of the annual report on that date. And we should be pulling together, we're just pulling together the analytical review that will go with the annual accounts. And then we will get that out to the Audit and Risk Assurance Committee for them to view in sufficient time before the meeting that we're having on the 20th.
Thank you, Azra. Thank you for huge amount of work's gone into this and getting things done so swiftly as well in such a difficult time. Any questions, observations for Sally or Azra? If we are content, I take it, Joe and Stephen, for this to go through to A&R for approval?
Yeah, good for me.
Fine, thanks very much indeed. If we can move on to the next item, which is PQAC, please, Yemisi.
Hi. Okay, so most of what we discussed at PQAC over March and April has actually already been covered in above items by Sue in terms of risk, Iffy in terms of governance arrangements around COVID, and Ian in terms of the operational update and the revised dashboard. So I don't propose to go back through it. General comments in terms of the COVID dashboard, as Ian has already said, we are looking to further develop it as we go along to capture more of community data, and not only in terms of quantitative numbers, but to add a bit more context to the information that we bring back to PQAC and to the board. The other areas that I wanted to highlight are those things that have been put on hold because of COVID, and predominantly we're talking about patient experience. There was national guidance to show that they've ceased collecting FFT scores, and they have given a different approach to how complaints are being handled. We still collect some data in-house, but I think we are going to have to look at the way we continue to do things internally so that we don't lose the voices of service users and friends and family till we go back to a new normal way of doing things. In terms of complaints, that's now been streamlined. So basic complaints or more straightforward ones are getting a light touch, and anything more complex goes straight to the Director of Therapies. Also, we discussed clinical effectiveness issues. So in terms of the audit, again, there's guidance, national guidance to say that they could cease, but we continued to do them in-house. So things like the care planning audit we're still doing. And that's worked quite well, because we are then utilising staff in slightly different ways in order to ensure that those audits continue to be done and processed and reported on and actioned. I think just the final thing that I wanted to mention was we gave approval for the implementation of quality impact assessments to be used for any service delivery changes that required a change in CQC regulations, and that came off the back of the PAS inquiry that was done late last year. So that was approved. So those were the main points that I wanted to highlight, but I'm happy to take questions on any other points.
Thanks, Emma. Steve Dilworth.
Yeah, Joe's already touched on this, so it's just building on that point. But on the ethics group, and I know on page 88 of the bundle, it talks about they've met 3 times and what the topics were. But I think from a good governance point of view for the rest of the board, it would be essential to see what was the actual decision that's been made, and also probably quite useful to see the context of that discussion. And as Suzanne has now told us as well, there can be decisions of more magnitude than I anticipated from just reading page 88. So we maybe don't need to decide it right now, but I think we need to do a little bit more work on that communication, making sure we all understand the decisions and how they were reached.
Yeah, that's not a problem, Steve. We did get to see the terms of reference and some of the issues, but I'm sure we can disseminate that to other NED colleagues in order for them to be able to get the context.
Yeah, I think I agree there. I think given the ethics group is dealing with such important issues, we need to see those, and perhaps a sort of separate report as part of PQAC. And if these are big decisions, I know it on that map we saw earlier, it's going back into the exec group. But I think if these are big decisions, I think we as a board ought to be aware of them. So we can think of some mechanism to ensure that we're kept apprised of those matters. I think that would be helpful. At the moment, we could touch on them at our weekly NED update. But as we move into the future, if we keep the ethics committee, then I'd like to see a rather clearer report at PQAC coming through to the board. Any other observations from anybody?
Just to say, Andy, the exec would take that away and come back with some ideas. Yeah.
Very grateful. Thanks very much. We'll move on to business committee. Joe, please.
Thank you. Obviously, the report is there. I'm sure everyone's read it. I'd like to just highlight 3 main areas. One is the close down of 2019-20, which I have to say, Azra and the team have done a great job on this. So I think it'd be worth the board recognising that. We managed to achieve probably as good a position as we might have hoped for pre-COVID. We are using some balance sheet non-recurrent, but probably less than we were forecasting. We had our COVID-19 extra costs reimbursed. The team dealt with some long-running overdue debts from other CCGs. I don't think they're quite entirely cleaned up yet, but a lot of them have been. And also achieved a great result on Sequins, in that it was agreed that we wouldn't have any penalty on Sequins, and that's going to be the position going forward when we return to normality. So great work there. And the result of all that is that we are in a stronger cash position than we anticipated as well, which is really good. Secondly, on bids and tenders, we've been tracking what's been going on with Startwell, where I think the board now know that we are running for Startwell at the moment a reduced service, more reduced than we even anticipated, because it's a service that is has been changed and limited as a result of current circumstances. And I think that's a 12-month contract now with a 9-month break clause from 1st of April. We also saw some numbers and the business case, a brief business case for what I think is now called the HMP Rochester Annex, which has now been opened, which is a sort of a maximum 70 prisoner mini prison in the Medway area. So we went through that, and I was cited on a very complimentary letter from commissioners on that. So well done to Keith and the team. And I guess the third area, which is the more who knows area, is the numbers for 2021. So clearly in these unprecedented circumstances, at the moment we aren't in the normal position of having a clear budget for the following year. What we've got is some arrangements in place which are very protective of the trust up until July, where effectively we're being reimbursed for costs, give or take, and we are continuing to collect COVID-19 related costs as well, and they will be reimbursed. And then after July, the budget is due to revert to, or our funding is due to revert to more normal arrangements. And I guess sitting here and listening to some of the things we talked about earlier, I don't think there is going to be a sudden cliff edge on this. I don't think the world is going to quite go back to where we are. So I think the whole exec and Azra in particular and the team, there's going to be a lot of ongoing work to work out what those numbers should look like post the sort of the current funding arrangements with the centre. And in particular, picking up the issues of demand and capacity, and indeed in some areas what services we will be running and how that relates to other organisations within the ICS. I think there's a lot of work to do. Azra, is there anything you want to highlight beyond those points?
Well, I think the only couple of points I want to just highlight for people in recognition for the Audit and Risk Committee. So you've seen attached to this the PSF position that we had. So we should be aiming towards, before impairments, a £3.5 million surplus. Once those impairments are put through, it's about £5.7 million. We will be showing a bottom line deficit in regards to that position. So it was just a bit of a pre-warning there. And then in regards to the 2021 position, I had my first sight last night of early indications for month one. So can confirm that I think with the top ups and the COVID-19, we should absolutely cover our month one costs. And there'll be a couple of variables, I think, that will adjust those costs up and down. One of which will be UEA, the second of which will be the sickness levels and therefore what the bank and agency spend will be taking through during those 4-month periods. As I'd alluded to earlier, we will be, as an ICS, and we're very much part and parcel of the ICS when we're driving up those plans, be developing a plan now over the course of May for what our response is going to be on the 18-month recovery period. And I think coming out of that, that will then reflect back in regards to what the financial plan will look at post-July. And we'll be feeding that back through the business committee and then back to the board as and when we've got that landed. I think that was the only issues I was going to raise over and above what you've already covered off, Joe.
Thanks, Azra. Steve Dilworth.
Thanks, Andy. Just to firstly, just to echo Joe's points, I was speaking to the external auditors first thing this morning, and they certainly are very appreciative by the great work being done by the finance team in what is a very difficult time. But they're getting everything they need and deliver very speedily. So that's working very well. Couple of questions for Azra on the AFC funding and the arrangements with local authority commission contracts. It's fairly material, 650,000 at play. Any views on how that's progressing, if at all? And if a further question to wrap into that, we touched earlier, Suzanne touched now on the capital programme. I think it'd be good, Azra, just for you to say a little bit more about that in terms of within the ICS, that our hand, although we will be presenting our case for any capital expenditure, it does become an ICS decision, and the difficulties that potentially could cause for us in terms of using our own funds and sovereignty. Any views on that be useful, whatever you want to say. And then finally, just on agency and bank spend, and in fairness, Iffy and Ian have commented on this before, just that we need to be cited on the improvement on agency spend, which is the main focus. It has been fantastic. If you add agency and bank together, in fact, we are about 9% over on where we were for 2019. But having said that, as Iffy has said before, Of course, bank staff often are going to be a lot better than agency staff, so it's not a bad thing. And we have been under extraordinary pressure during the the last few months of the last financial year. But just for transparency, I think that the board need to be aware of it's good to look at the agency and bank spend together. So at the end of all that, 2 questions I think really for Azra. One about the capital programme, and secondly about AFC funding.
Okay, so I'm going to take those slightly in reverse order because that's the way you originally laid them out. So in terms of the local authority funding, it's been quite quiet, I have to say, from the local authority. But for that April to July period, we will absolutely have any issues covered off via the block and the top-up arrangements we have in place. We've written to the local authorities, but we haven't had a response back from them. And I'm assuming that this is due to the inundation that they've also had, to the response that they've needed to make to the COVID-19 pandemic. So we'll be stepping that up over the course of May and June to ensure that we have a landed position ready for the July period. But I wouldn't have an update over and above that, I'm afraid, for the board at this moment in time. Coming back then to the capital issue, just to contextualise what this looks like. So originally, if you'd added up all of the organisation's capital plans in the pre-COVID-19 period, we had a capital plan for South East London ICS of 335 million. We were then informed, basically at the tail end of last week, that the ICS would be issued a control total for capital. And that control total has come out at circa £176 million, which is broadly about half of what we were originally planning for. And that's not quite as severe as it may look at first instance, because the COVID-19 costs, capital costs, will be reimbursed outside of that control total of £176 million. And B, there are a number of plans that wouldn't be able to go ahead as planned under the C19 conditions that we currently have around building, just simply about the fact that you would not necessarily have builders in place. Initially, I have to say, there was a quite worrying methodology that was brought down, which was replicating the national methodology for how they issued the control total of 176 that they were going to apply to each one of the organisations. And we've met twice now as a group of South East London Directors of Finance just to establish what a better process would be. And they've decided that they are going to go down a route that is a bit more linked to how much internally generated funds that we have. The good news for Oxleas on that is against an original programme that we had of about circa £22 million. Just about £20 million of that was covered by Oxleas generating their own, it was all internally funded, and therefore our programme should be nearer that. I've had a meeting with Ian, Alison and Rachel last night. We are now forming together what we think we would be able to do given the current circumstances that we're operating in terms of a forecast for 2021. That will be influenced by both how likely do we think we would be able to get the building work done, but also some of the work that we would need to reshape in regards to we may want to put more into the IT element of the plan for 2021 rather than the estates plan, to make sure that we are able to appropriately respond to the COVID-19 response. We're going to take that through the executive and the directorates next week. I have my next touch point with South East London ICS on this topic on the 15th of June. The 15th of May. And what we will then do is, I think we need to then have an extraordinary touch point with the infrastructure committee before we have to put in a final return as an ICS on the 29th of May. So there's quite a lot of work to be done within that. And I think really it's about how we as an executive and as an organisation interact with the ICS, because they've tried not to do so much the imposition piece, but tried to have all partners working together. So that ability to be able to influence what the overall Oxleas position was going to be, it was very helpful having that set of conversations. but it does change very significantly the way that we used to previously deal with capital, where it was effectively, it was all within our hands. Whatever we were able to internally fund, we could spend on capital. We now do need to keep an eye on this overarching control total, and there will be a set of decisions that may possibly come back where we would not be able to spend as much as we would wish because the overarching control total figure is not large enough.
Thank you very much indeed, Azra. And if you know, on behalf of us all, thanking you and your team for the work that you've done to get us into this position so promptly and swiftly, and you know, with great credit to you, your leadership, and your team. Thanks very much. Are there any other comments or observations before we move on? If not, yeah, Missy, I neglected to at the end of the last item to thank you very much for the work that you're doing on PQAC and the content of that report you presented today. I've got a staffing issue down at this end, so I want a 10-minute break, if that's okay. I haven't had a cup of tea for a while. I don't know what's gone wrong. So what's the time now? So if we were to say 12:15, would that be okay for everybody? Remembering you're on the big screen, it's all being recorded, so your sartorial elegance will be noticed, so you may wish to switch your cameras off before we resume at 12:15. Thank you. Right, if we go back to our agenda, and it's Suzanne, are you ready on Infrastructure Committee, please? Thank you.
Thank you, Andy. So a large part of what we discussed at the Infrastructure Committee has been covered by Azra in her update. As sort of happening quite frequently at the moment, by the time papers come out, we've been superseded by events. So the meeting focused on two other major issues. One was just understanding some of the work that had been done by our estates and informatics teams to respond to the pandemic. And I do want to take this opportunity to thank them hugely for the work that those teams have done. I don't know how far when people are out at night applauding the NHS on the sort of Thursday night clap, whether what they have in mind are the people who are working in the background, for example, manning our helpline for staff who are working from home and need informatics support, or thinking about some of the people who are supporting keeping our estates clean and functioning and safe. But you know, they've done an amazing job and have adapted very, very quickly to circumstances. So I really do want to express public thanks to them. We did spend some time in the committee hearing about some of the innovations which had happened. That, you know, there's the kind of obvious stuff about people working from home, but there are all sorts of imaginative and innovative ways in which people have been using the capability of the technology that they've had in circumstances which they hadn't envisaged before. So, for example, using tablets to show relatives what you know, facilities might look like. And I think one of the things that we recognised at the committee is that we really do need to find a way of capturing not just the big things which have been done, but a lot of those little things. The other item that we spent some time on that hasn't been touched on yet is about the QMH theatres upgrade. Board members will know that this has been on the runway for some time, and that unfortunately the upgrade came out as a bigger cost, quite considerably larger than we'd originally intended. So we were briefed on a different way of approaching the procurement, by which, in effect, the kind of financial risks that might go with design problems would fall on the trust rather than on the provider, the contractor. Because of the size, you know, the magnitude of the changed costs, there will have to be a new case coming forward for the increased expenditure. And there has been some discussion with our users at the QMH site about the value to them of having the upgrade done. And I think that what, if he has heard through his network, is that there is that our partners are keen that we should go ahead with this. That does just take me to the final point, which is to thank Azra for the update she's given us today, and for, as I said earlier, kind of fighting our corner, as it were, with the ICS. One of the slight concerns that I have going forward is that there are going to be possibly some important decisions made about priorities in the next month. And I would like to request that whilst we do have an emergency or exceptional meeting of the Infrastructure Committee, that we have some sense of the emerging discussion prior to that meeting, so that it's not a matter of being asked to endorse a final decision. So if I could sort of pick that up afterwards with Alison, Rachel and Azra, I would value that.
Thanks, Suzanne. Any questions for Suzanne at all?
I think, sorry, Anne,
yeah,
just to say, I think probably the feedback from the end of the touchpoint meeting might be quite a useful period to do that. So the end of next week, both myself, Ian, Alison and Rachel will have had a chance to actually do what we think the actual forecast needs to look like by then. But B, I can feedback, is it still looking at the same levels of principle? So I'll email that round to all of the infrastructure NEDs, and then happy to pick it up with a phone call if required afterwards as well.
Great, thank you very much, Azra. I think that'd be helpful.
Okay, thanks very much. Is there anything else at all, Suzanne? If not, we'll move on to the next one. Thanks very much. If we can go on to item 13, workforce, with Nina, please. Thank you.
Thanks, Andy. I will keep this brief. I just want to, feels like a very long time ago that we had this meeting on the 18th of March, but Rachel and team have been superb at keeping us informed of important updates over the last few weeks, in particular on emerging issues such as BAME. So I will touch on the headlines of the points that are covered in the report. We deliberately, this was in the very early days of the response to COVID, and we deliberately focused on those issues that we considered were of an urgent nature in light of COVID. We, on the health and safety side of things, focused on the remaining vacancies in the health and safety team. I wanted to make it explicit to Rachel T. Evans that she could count on support to take whatever measures might be necessary to achieve her full complement. We had an update on the report on the lift incident at Barefoot and discussed a number of additional actions that we felt were necessary. We noted the increase in the uptake rate for the staff flu vaccination. I have a feeling that going forward, people's views of vaccines, not just at a staff level, but more globally, are going to be quite significantly impacted by the learnings of the events that we're going through at the moment. On KPIs, we recognised that it wouldn't be possible to maintain some of the very good momentum that has been built up in recent months, given the period of crisis, and Rachel C. Evans is coming back to the next meeting of workforce with views on what we should be stopping, in inverted commas, or pausing or starting, and a number of those initiatives, as I say, she has been taking forward with the support of non-exec members of the Workforce Committee over the last few weeks. We noted the response rate for the staff survey, which was superb. We noted those areas where we remained consistently above average, and we noted that there are programmes of action ongoing in the areas where we need to improve, which are violence, bullying and harassment, and equalities. On bullying and harassment, we had an important discussion on an acknowledgement of the fact that in periods of additional stress and pressure, that can impact on behaviours that could fall under the bullying and harassment, fall into the category of bullying and harassment. And comms have been incredibly clear and supportive and regular, and there have been additional steps taken, including webinars for managers to guide them through how to manage people through more stressful periods. And there's also guidance that's being shared about resilience as well. I think those are the headlines that I want to touch on. Rachel, is there anything that you'd like to add?
That's fine, Nina, thank you.
Any questions for Nina or Rachel at all? If not, then thanks very much indeed for all the work you're doing on that. If we can move on now to Audit and Risk, and Stephen, please.
Thank you, Andy. Well, like Nina, I look back at these minutes of the 17th of March, where we were vaguely talking about remote working, and I realised just how much life has changed in those just 6-week period. Two things really to report on. First of all, on the KPMG internal audit report around business cases. So the outcome was quite good, significant assurance with minor improvements. However, the committee in some respects took a slightly tougher line on the frequency of business case monitoring. So the internal auditors were talking about a 6-month review after a project has started and the business case has been agreed. We thought that would be a minimum standard that we would set. We would quite possibly, on some big projects, want to have an earlier review. And indeed, that for most projects as well, we would want a clear statement at the outset, which talks about the key performance indicators and the key expected outcomes that we could expect at an early stage. And I think for all of us, we'll remember back to, say, the outset of Bexley Care, where maybe we could have learned from that, and we need to learn from that going forward. But anyway, that was, I think, an important point in this, that we think the monitoring needs to be a little bit tougher than the internal auditor was recommending, and also, as you'll see in the text, that we would align the business case process more closely with the quality impact assessment process. So it's making sure that the business case isn't just about the financial considerations, but quality impact becomes particularly important. The other thing I would just want to draw to your attention is at the end around risk appetite. And certainly this is something that COVID-19 has obviously delayed. We had hoped to have this coming to May or July boards, that we would have a firm policy, but of course we haven't been able to do the amount of consultation that we would have liked. So what Sue Owen and myself feel would be appropriate if we would bring something to the next strategy day to take the consultation a little bit further. Obviously, we appreciate that people will be joining virtually, but nevertheless, it would be good to get some feeling from attendees as to the degree of risk they are willing to entertain in various scenarios. So that would be good to get that moving forward. Of course, it's strange that this is exactly what we're now experiencing, exactly the sort of massive change in a crisis, where in fact a risk appetite policy would be immensely useful. We're not alone within the NHS. That's probably the majority of organisations don't have a fully developed policy on this. But I think it has highlighted in the last couple of months that we need it. We need one. So I really would like to get that done during 2020. The next key step on that, as I say, will be some discussions of the strategy game. Azra, I don't know if there's anything, or my fellow Neds, anything else you want to add to that? No? Happy to take questions.
I can't see any questions there for Stephen. So again, thanks very much indeed, Stephen, for a really thorough and comprehensive report. If we could now move on to board contacts. Firstly, yeah, thanks to everybody for being imaginative in the way that you're going about doing this. I think it's really important that we keep in contact with our services. Obviously, we've got the reports in front of us, but any issues that people would like to raise with us? Start with Steve James to Mulbrook and Leslie.
No, not really. I think it's there. What it did for me was to highlight the importance of local management. I put in the report that it was incredibly calm, both wards, and I think that very clearly came from the ward managers and the modern matron. And we just need to remember that it's such a key ingredient of a good service. There are some small things like the privacy around the doors which need to be addressed, because CQC will pick them up. And the other thing that just surprised me was that the body-worn cameras were very popular with the patients, who thought that they were a very effective way of protecting their safety, which is something I hadn't anticipated. But no, it was a very successful visit. And I have to say, all the virtual visits that I've done with Bexley teams have been very reassuring as well. I think they're well managed, they understand the pressures that they've got, and they're very good at allocating resources, people by and large, between teams to address whatever issues are in particular teams. So actually it's very impressive, the Bexley stuff at the moment.
Thanks, Steve. That's really reassuring. Joe, special schools.
Yeah, so I'll pick up both mine at the same time. So I think I did a verbal on this at the last board meeting, and the only thing I would highlight, which I know chimed with a number of us and I think fits in with our sort of workforce wellbeing agenda, is the fact that, you know, some of the children this team works with have life-limiting conditions where, you know, and it does take an emotional toll on the team. So ensuring that they've got the right support there, I think, is really important. If I then move on to sort of virtual meetings, so I'm still looking at the CYP directorate. So Lisa and I have got a regular call every 2 weeks now, and then I'm just starting to do sort of team meetings. So both Ian and myself dialed into the CYP SMT, last week or the week before, and then I'm arranging a series of other virtual meetings. You know, I guess, you know, in line with actually what we find when we go to visit people. People staff are very straightforward about what they talk about, and you know, chime, and people's thoughts are really moving now to what's the next phase like. So because there's an amount of stability at the moment, there's still been some movement in the CYP services around. It's taken a long time to get the emergency department path at QE for 16 and 17-year-olds who present. I think that's finally settled, and effectively they're going to be seen within ED. But other than those sort of small changes, and also Ian referred to the fact that we're working with Demelza now, which enables another 3 children to come out of hospital and come back to Demelza. People are really thinking about the next phase and what's positive about the new way of working. On the last call, and I've heard this comment in different situations on some of the other work I do, I think the fact that some people are spending so long on conference calls all day, or WebExes or Microsoft Teams, that does take quite a toll, because you've got just full-on formal communication, which is a bit different to if you're in the office and you have a couple of meetings and then you sort of pop out and get a cup of coffee and have a nice chat with someone. So definitely thinking about how we can take forward the positives of the way we're working now, but in a measured way and in a discriminating way, to improve the solution going forward. But really good meetings.
Well done, Joe. Thanks very much. I think it's a really good point about the teleconferences and the phone conferences, and just for some of our staff, I think they're really quite draining, actually, spending all day on the screen. But thanks very much for that visit, those updates. Suzanne.
Thank you, Andy. So I've been keeping in touch with our prisons service managers, So far, I've had a couple of calls with Himi Baksh at Wandsworth and a call with Sunita Arjuna, who's leads on the Kent prison cluster. It was striking that when I first spoke to Himi, he was himself compelled to work from home because his wife had COVID. And I think it's probably been quite a stressful time for him because she had COVID, went back to work and then became ill again. But when I last spoke to him, she was recovering well, which I was really pleased to hear about. So I'm not going to say anything more than I've mentioned in the reports, really. I think all things considered, the prison situation is better than I had anticipated it might be. I did want to, as others have done at this meeting, call attention to the incredible work that Sunita and her team have done to get HMP, what's it now called, Rochester Annex, up and going. It was a remarkably rapid mobilisation, which she got on with and have done very well. And the other thing I should draw attention to is that the HM Prison Service was themselves, I think, concerned about the situation in prisons. So having suspended their visit programme, they have reinstated it, but without the CQC visitor who would normally go with them. And I mention that because they've now visited both Wandsworth and Cookham Wood and have been complimentary about the healthcare that's being provided there. And the last thing to say, and it just to be on the record about this, the one service manager who I haven't spoken with is the lead on the Greenwich cluster. And I think I will now highlight making contact with them as a priority. And I'm interested to hear from colleagues that they've been joining team meetings, because I think that could be quite a constructive thing to do, and I'll try and introduce that as well.
Thanks very much, Suzanne. That's really helpful. Thank you. Stephen Dilworth.
Thanks, Andy. Yes, as with my colleagues, one never stops being impressed by the amazing work of staff under the current conditions. Ify and I had a good conversation with Lorraine on the 16th of April. It's interesting looking back at the executive minutes from the 14th of April, a couple of days before, because they talk about problems at staffing at Green Parks House and with PPE. But in the 2 days interval before we were speaking to Lorraine, they have basically both been sorted out. So she moved very quickly on those matters. Staff morale was good. PPE was good. The staffing situation had become stable. So basically, much better than you would generally expect. I was interested, she makes a reference, and it's in the text, about the, she did mention mind, but generally the difficulties that our partners were experiencing, particularly charity partners, and no doubt that will become an increasing problem over the next couple of months about the resources they've got available. So something for us to keep an eye out for, as that will start to affect the way some of our services operate. But apart from that, generally a good meeting. And the next one we've got planned, which will be later that month, we're going to bring in some more of the other staffs so that we can have a virtual connection with them as well. And that's all.
Thanks, Stephen. Amlan, you're going to do us a verbal update, please?
Yes, happy to. So I spoke to Lorraine as well with Alison a couple of weeks ago, but particularly focusing on the adult learning disability services. Found it a fascinating conversation, and happy to do a written follow-up, of course. But I think the main points that I took from the conversation was that there's been a huge amount of thinking forwards, which I was impressed by, particularly in relation to kind of bits of good practice that we could cling on to kind of moving into next phase, which I thought was forward-looking and impressive. They have done their best to use technology as best as they can, I think very effectively. They were, even thinking of trying to do maybe some of those sun groups that we heard of in previous board meetings, maybe via webinar or doing a Q&A, which I thought was a great idea. They're conscious that there have been increased mortality kind of in the community generally. I think year on year, Lorraine suggested there have been kind of 3 times as many, kind of 11 deaths this month, kind of in the community broadly, which is obviously very difficult for services. They've been coping well, I think, with the increased data reporting requirements. Of course, there are going to be increased pressures on services to report more data for dashboards and things, but I think in general they were understanding of that and compliant. And just finally, I thought an interesting point was that now that they are using phone appointments and kind of WebExes more for keeping in touch, they've actually noticed a decrease in their DNAs in that service, which I think is really interesting. And again, a real nugget maybe for engaging more effectively ongoing rather than just for this period. So interesting conversation.
Thanks very much, Amlan. That's really very, very helpful indeed. There'll be a lot of interesting things to come out from this, won't we, about our appointments online and the difference that may well make. Again, thanks to all our NED colleagues for all the hard work you've been doing on this front. I think it's really important we stay in touch with services, and the feedback I get it is very much valued by the teams themselves for your concern and interest. Sally,
can I just give a really quick update with forensics?
Of course.
Yeah, so I've been keeping in contact with Keith Soper about forensics, and he's been giving me an overview as to how that's been going. And then I also sat in on a forensics referral team meeting on 23rd of April. It was a really good meeting, and it was a pretty large attendee list, and they conducted it by telephone as opposed to video conferencing, which actually made it quite challenging for me, and I suppose for the attendees, because obviously they all those verbal and visual clues weren't there. I did pick this up with Keith later, and he said that they were getting video conferencing equipment installed, and they were just waiting for the cameras. But I think this may be more of a question for Alison. Are there other teams, departments around the trust that have large attendee lists where they don't have that system in place yet?
Yeah, I mean, I think it's a mixed estate. So certainly there are parts of the organisation that we want to be working with to facilitate that.
Right. I mean, they coped really well with it. I just think it would be beneficial to, I don't know, maybe prioritise them, because it was such a large group, and it did make the meetings a bit difficult. Yes. And it took slightly longer than maybe it could have occurred. And I think the only other thing that I picked up that was a surprise was apparently some of the prisons are charging us to use VC links in the prisons. Is that true?
I don't know, actually. I'd need to follow up with Keith, so certainly something we can take offline.
Right. Okay, that's fine. I mean, when I picked it up with Keith, yes, there was a charge, but the way he saw it was that the charge was minimal to the staff travelling all the way to the prisons in terms of times, like staff costs from that point of view. Yeah. But it would be interesting to find out if it was just this particular. I think HMP Bedford he mentioned, and there could be others. So I think that might be worth picking up.
Okay.
Yeah. But apart from that, that was it. They seem to be managing well with their challenges. They seem to be very reactive with the challenges that present them, and they've managed to get their staff's absences under control. So yeah, I was really pleased with the feedback that I got there. Thanks, Andy.
Thanks very much, Embassy. We'll move on now to the governors. You've got the report in front of you. Richard, do you have any observations at all? Or Christine?
I think it covers what's been going on. Clearly, the role of governors has had to be somewhat curtailed during the last couple of months, and I suspect it will continue to be so for a little while ahead. Certainly, as I said earlier when we were just talking with the Neds, I've certainly welcomed being part of your briefing group on a Tuesday lunchtime. I've learned an awful lot from that. I know from one or two governors I have spoken to, they really appreciate receiving the Monday, Wednesday, Friday evening notes that are circulated from Ian, which sort of keeps them in touch. Clearly, we've got another Council of Governors meeting coming up in about, or just over a month's time. I think it's about 5 weeks or so. We'll have to think carefully about what we want on the agenda. I'll try and feed back, and I'm sure in preparing the papers, Sally and colleagues will as well, on making sure there's relevant material there. But clearly, if there's anything that any members of the board would particularly want on that agenda, either let yourself, Andy, or me know, because you and I'll have to get together probably in a couple of weeks' time and put together the agenda for that next meeting. But no, I think this has been a good meeting today. It's clear people at Oxleas are getting very experienced at using this technology, and I think anybody who looked in to realise this was the first board meeting, the formal board meeting done on a virtual basis, would be very impressed, both in the amount of material that's been covered and also the contributions that are being made by colleagues, whether they be exec or non-execs. Thanks.
Thank you, Richard. That's very kind. Thank you. I haven't been notified of any other business, but is there anything anyone would like to raise at this stage? If not, can I just reiterate what we've touched on earlier, but our thanks to everybody within all the workforce of Oxleas. I particularly want to thank you, colleagues who are here now, for your, I think, quite outstanding leadership during this time. I think your sheer hard work, your obvious compassion and your forward thinking, I genuinely think that your efforts have been absolutely outstanding, and huge credit to you for everything you're doing during this this emergency period that we're going through now. I do worry about your welfare. I do worry about you making sure you do have time off. It was touched on earlier about just how wearing sometimes these teleconferences and phone conferences can be all day long. And I know it's a bit of a cliche now, but this is a marathon. We don't know how long this is going to go on for. So looking after yourselves and paring back some of those meetings, perhaps if you can, might be helpful. I hope I've done my bit to make it one of the shorter ones we've done. But anyway, thank you very much indeed for all your contributions. Letting Steve Cooksley know that we are now signing off now, and look forward to speaking to you all, no doubt, on Tuesday. Anyway, thanks very much indeed, everybody. Thank you.